Good morning, one and all. First, I would like to thank Mila for giving the chance, and I thank the organizing committee for giving the opportunity. My topic is after Rohit's and Ranjani's topic, it is little different. I'm going to share our experience with AI. Okay, so AI-assisted HER2 IHC classification for optimized treatment decision making. This is my title. It took little time for me to understand first. So coming to this, everybody knows breast is a heterogeneous disease. So new cases have been diagnosed day in, day out, and nearly 5 lakh cases have been diagnosed in the year of 2022 itself. So the biomarker testing now it has become mandatory at the time of primary diagnosis, and in cases of metastatic diseases, and whenever there is a recurrence, again it is asked to reassess the biomarkers. And the molecular subtyping is based on the biomarker testing. And the staging is also, we all know, staging is done by the clinicians and with the histopathology specimen. So the treatment decision is made so far using it is guided by the clinical stage and histopathology features and the biomarker profiling. But now the scene is changed. So the subtyping using IHC, it aids in the adjuvant treatment decisions, because everybody will be working whether it is luminal A, luminal B, what does it matter? Why should we know? But if it is luminal A and B, that is ER/PR positive, so the patient is eligible for hormonal therapy. If it is HER2 positive, then HER2 targeted therapy. And all the things are negative, then the patient goes for chemotherapy. So the treatment is decided upon the pathologist. So now pathologists have a better role than the past. So why HER2 testing is critical in breast cancer? Because I have already mentioned, for guiding the clinicians for targeted therapy, because there are many monoclonal antibodies and the antibody conjugates which have been coming into the market, which is targeting the HER2 receptors, and it gives the prognostic and predictive value. So shorter survival can be predicted if it is HER2 positive, and early relapse after chemotherapy also can be predicted. And the amplification or overexpression occurs in approximately 20% of metastatic breast cancer patients. So at the time of diagnosis, if you diagnose the patient is HER2 positive, you can predict that the patient might develop metastasis, so you have to constantly follow up the patient. And ASCO and CAP guidelines continue to evolve. Every 3 years, 2 years, the new guidelines are coming, and we have to update ourselves to address the diagnostic needs that optimize the testing in clinical practice. So what are all the different HER2 testing methods? First is IHC, which is the basic testing method, which can be followed by in almost all the labs, and it uses the antibodies to detect the HER2 protein expression. Next is FISH, fluorescent in situ hybridization. Other thing is SISH and SISH, all are in situ hybridization techniques. Here they use the DNA probes to see the HER2 gene amplification. And dual SISH, it is having 2 probes, so that one will be targeting the centromeric probe, another one is HER2 probe. So previously, interpretation was binary. Why I am telling was means till 2022 it was binary, but now it has been changed. So interpretation was binary, that is either positive or negative, based on the validated IHC and ISH assays. That is HER2 negative and HER2 positive. If it is in between, that is equivocal, again we have to do ISH. If it is positive, then positive. If it is negative, it is negative. Now the scene is not like that. So dual pro-FISH, we all know, according to this reporting, we divide the categories into 5, group 1, group 2 to 5. In this, group 1 and group 5 are definite cases, 2, 3, 4 are again need reflex testing. So what is the changing paradigm of HER2 interpretation in breast cancer is, currently according to the 23 guidelines, ASCO and CAP guidelines, the IHC 0 category, it is divided into 2. One is no staining, means it is null category. If it is less than 10% of faint staining, is called HER2 ultra low category. And HER2 1 plus has become HER2 low, and HER2 2 plus, where the ISH is negative, has become HER2 low again. And HER2 2 plus with FISH positive, it turned out to be positive, HER2 positive. And HER2 3, IHC 3 plus is HER2 plus only. So the positive and negative has been changed into null, ultra low, low, and HER2 positive. So there are differences in staining patterns, and now it has become very important to diagnose 0 null and 0 ultra low and 1 plus, which cannot be done in 10 plus and 10x and 20x. Previously, if it is 3 plus, we can see it in 10x itself, and 20x we can confirm it. No need to go to 40x at all. But now we have to see it under 40x magnification to differentiate between 0 and 1 plus and 2 plus. So national NCCN guidelines in 2023, they made it mandatory. Why it is very important to diagnose 0 and 1 plus? Because there is a targeted therapy, now it is available in the market. So the patients will be having extra advantage if they are zero null means there is no treatment. If it is ultra low or low, there is a treatment for the patient. So how can we achieve it? By following good laboratory practices, so that we can accurately identify the HER2 ultra low breast cancer by scoring only the invasive areas. This is the mistake most of the juniors they commit. They just, because when they put the HER2 slide, it will be brightly positive, but they don't see whether it is in the invasive area or in the in situ area. So if it is in situ area, it doesn't have any it is not considered as positive. We should see the invasive area. And we should never hesitate to consult with our colleagues whenever we have a doubt. And whenever we have an ambiguous case, and when we are doubtful whether it is 2 plus or 1 plus, we should be open and discuss with our colleagues. And using controls, this is the new thing. Now they are making it mandatory. That previously we use only the positive controls, but in HER2, now they are insisting all 3 controls we have to use, so that the range of expression we will be knowing, we can compare with our test value. And we should consider only the linear membrane staining, not the cytoplasmic blush. And now the ICE protocol, that is intensity, completeness, and the extent of staining, that is called ICE protocol by CAP, to detect the faint staining. So it is useful to differentiate between ultra low and low. And everybody should participate in proficiency testing so that we can improve our efficiency. So now coming to the actual topic, why AI? So because we are doing a good job so far, why should we have an artificial intelligence? Our intelligence is sufficient. Key unmet need remains the improvement of concordance, because what I report as 2 plus, Satish will report it is 1 plus. What he reports 1 plus, I will report as it is only 0. So this kind of discordance happen among the pathologists. To overcome this, and because why it is happening means it is subjective. If I see it in little high power, that is the thing I told. If I go in 40x and analyze completely, then my 2 plus might become 3 plus also. And there is no definite methodology for quantification, especially regarding the cutoff values. Cutoff value means 10% is the cutoff value. But the 10%, to arrive at the 10%, it is very difficult, because 15% becomes positive. But that 15% means we have to count 100 cells. The 100 cells which I count, maybe Dr. Satish may not be counting. He must be counting the different things. So this kind of discordance happen between the pathologists. That is why the reporting is subjective. So changing guidelines of the reporting, ASCO and ESMO, they have different guidelines, and so the pathologist should participate in focused education and training programs on how to report. So how does DP, that is digital pathology and computational pathology, differ from conventional pathology? So conventional pathology, Dr. Rohit has already mentioned everything in detail. I don't want to go in detail. But in this, after the scanning of the section, the AL, that is machine learning has been introduced, and that reports on its own. So that saves the time, and the pathologist has a comparative thing, manual reporting and the AI reporting, they can compare and release the definite report. So we have done a project with MindPeak and AstraZeneca, and I would like to share our experience, how the AI assisted us and made our reports more accurate and clear. So this is the poster which we presented in the ESMO conference last year with the project. So according to the project, 150 diagnosed HER2 slides have been, invasive breast cancer have been selected, and H&E slides are analyzed by 2 pathologists, and then HER2 staining is routinely done and routinely reported has been taken into account, and another pathologist looked into the H&E slide manually, and then all the slides are digitalized using Morphle scan, and the whole slide imaging again anonymized. So all 150, because 150 we could not get, I think 138 we have got. So the ground truth may be the expert pathology opinion, the report which has been released is considered as the ground truth, and 2 pathologists are assigned for the study, so they are blinded to the ground truth. So what is the actual report, nobody knows. The 2 pathologists saw the slides, digitalized slides separately, and they reported. After a gap of 15 days, that is the washout period, then the AI software which is given by the MindPeak has been introduced in our system, and the same 138 slides are screened by the same 2 pathologists in a separate cabins, and the reports are analyzed and we got the publication. So the example, this is the digitalization slide. So I think everybody can make out the diagnosis. It is 0+. With the AI software has 4 color codes. One for negative tumor, that is yellow. Another one is partial tumor, is light peach color. Then complete weak tumor is maroon, and then red is complete strong tumor. So these 4 colors are given to 4 different cells. So whenever we put the digitalized image and add the AI, we get the reading. I think everybody can make out. Sorry, this thing you can make on the right side. The reading will come. What is the percentage of each cells? So we can filter it also. I want only the complete strong staining. I want complete weak staining. Like that, you can filter the images also. So this is reported as, because we removed all the negative thing. Only complete weak we have kept. It is hardly 0.2%. So it is 0 only. So in the 0 slide also, we had no pointer. Pointer is not there. It's okay, no problem. So here, in some cells, there is incomplete faint staining. So it can't be 0. It can't be null. It is ultra low. So this is 0 ultra low. So according to the ASCO guidelines, it is 0 negative, but according to the ESMO guidelines, it is HER2 ultra low. In the other slide, it is total null. Here, according to the ASCO, it is negative. Even ESMO also, it is HER2 null. It is not negative, it is HER2 null. So like this is a second example we can make out. It looks like 1+. So let us see the population of the cells. Here the negative is 79% and complete weak is 0.7%. If it is more than 10%, then we can call it as 2+. Okay, so we filtered out. We just want to see only the negative cells. It is occupying 79% of the population. So according to the ASCO guidelines, it is HER2 negative 1+, and ESMO it is HER2 low. It is not negative, it is low. So coming to the example 3, it is 2+, I think you can make out. And here again the 4 color pattern. Here complete weak is 32%. So that means it is 2+. Because it is not complete strong is only 0.4%. So if it is more than 10%, then you can call it as 3+. Since it is 0.4%, we should call it as 2+ only, and machine also called it as 2+. So complete strong is only 0.4%. we can filter out the other things. So this advantage is there in the AI, which helps us whenever we have a doubt. So what is this thing for us means this 2+ and 1+, we had a difficulty means we use the algorithms. So this is the 2+. So according to the ASCO and ESMO thing, it is HER2 low only. Whenever the HER2 equivocal is there, we have to do FISH testing. If FISH HER2 is amplified, then it is considered as HER2 positive. If it is non-amplified, it is called as HER2 negative. According to ESMO, it is HER2 low only if it is non-amplified. If it is positive, it is considered as positive. So the example 4, it is nothing but 3+. So here the complete strong is 38.3%. So that confirms that it is 3+, and we filtered out all the negative and the complete weak and all that. So complete strong is 38.3%. So it is nothing but 3+ HER2 positive. So what is the comparison? So comparison, we did it in phase 1 and phase 2. So phase 1 without AI, 2 pathologists. So what is the result means? There is a highest agreement, as we all know, in 3+. 3+ nobody disagreed, both are concordant. But there is a lowest agreement in 1+. So according to the other study, compared with the other studies, our study 1+ we had more discordant than 2+. And in phase 2, that is using with the AI aid, the accuracy has increased from 71.7% to 80.4%, and accuracy of 0 and 1+ increase, that is also increased from phase 1 and phase 2. So the inter-observer agreement by score is also very compatible in 2+ cases. So AI assistance improves the scoring consistency and accuracy, especially for distinguishing 0 and 1+ cases. And adopting AI reduces the turnaround time. Why means? Because especially in the second opinion slides. The second opinion slides, they come from outside. Either the blogs or slides will be sent. We have to send the slide from, if it is local also, if Rohit is sending to me, it takes 2 days because 2 hours. He has to send it from there, and whatever he sends, if the slides are not clear, again we clean the slide, and again we see it under microscope. Then send back the slide, again it takes 2 hours. But if I have the digital with me, he can just digitalize the photographs and send it across. So in 10 minutes, I can get the slides and I can report, and he will receive the report in half an hour. So by this, the turnaround time can be reduced, and we have more time to do more consultations. And HER2 IHC interpretation is better with AI assistance because the accuracy, I have already mentioned, the accuracy in 3+ and 0, there is no doubt we can report this thing. Especially in 1+ and 2+, we have little. If you don't have proper slide, if the slide is not properly stained and it is very heterogeneous staining, means we have difficulty in diagnosing 1+. So AI assisted interpretation improves the pathologist's accuracy, reproducibility, and the efficiency. So each technique has its own challenges. Here, as they all mentioned, the availability of scanners is only 10% of the labs. So every lab can't afford the scanners, but there are many scanners. Now they are slowly coming into the market, single slide scanner, 6 slide scanners, which are affordable by a private lab also. Maybe in future, because when we were all students, we saw through monoocular microscope. So to see a binocular microscope, it was a luxury for us. So when we got a first binocular microscope, oh, very nice, no staining. Otherwise, we used to close one eye and one eye like that. We used to see under monoocular microscope. But now we have digital microscopes and digital images. So maybe 10 years down the lane and all that, even the scanners will become very cheap, cheaper than the microscope, and everybody can own a scanner. And the limited awareness and acceptance. Many people, they don't want to switch over to from the microscope to digital. That is the this thing. Maybe they are not comfortable, or even for us also, when we got the digital, we are little worried and we are tensed. Whether we are not confident actually, to be frank with you. I was not very confident because whatever I see in digital, I just bring the slide and put it in the microscope and see it again. Then only I am comfortable and confident. But we should get over that, and we should see daily the images and get practiced and go for training. So there are, and each technique has its own pitfall also. There are 3 cases where we had discordant also, because it is not 100% proof true. These are examples of 3 discordant cases. So I think anybody wants to comment on the slide? So manually we reported as 0, but AI reported as 1+. Maybe the background staining and the cytoplasmic blush and the thickness of the section is little thick, I feel. So the AI has interpreted wrongly and we released it as 0 only. This is a second case which we reported as 1+, but AI reported as 0+, that is ultra low. Ultra low is very difficult to pick up under the microscope, and the faint membrane staining and cytoplasmic staining, which we thought it is 1+, but AI has picked it up as ultra low. This is the case number 3. I think we can make out. We reported as 2+. I think all will agree with me, right? We reported as 2+, but AI reported as 3+, because 14% complete strong membrane staining is there, which is very difficult under the microscope for us to do the counting. So reflex testing is, usually we do equivocal reflex testing, and fish has turned out to be positive. So we confirmed that what AI has mentioned is right only. But all the time we don't go with AI also. And to summarize, AI is not a substitute to human, and it will assist us and make our work easier and faster. Proper training and awareness of digitalization is mandatory to implement AI. Development of AI dedicated solutions will need to be considered as a high priority in the future. So this is my team and my strength. Thank you.